And we'll plunge in just in the peripheral most extent of clear corneal tissue and scribe a gentle arc of 40 degrees. Move over nasally. Mr. Runkle will ask you to look to the right edge of the lights. Under topical anesthesia, of course, we can have the patient help us with exposure, or we can use our fixation ring to aid in moving the globe into an optimal position for a perpendicular approach with the diamond blade. Take just a moment to be sure the blade is seated, and then advance circumparallel to the limbus. A good speculum, particularly a locking speculum, will help improve exposure. Sometimes we actually have to adjust the speculum to bring it out of the path of the diamond blade. If the LRI was called to be greater than 40 degrees of arc based on the nomogram, we would still keep it in this range and then extend at the end of the case to prevent intraoperative wound gape. Tammy, we need you to irrigate the lower cornea, please. We have the viscoelastic attached to the cystotome, so we can fill the eye and then open the capsule. In shallow eyes, we would continue and complete the capsulorhexis with the cystotome attached to the viscoelastic such that we can immediately re-deepen should shallowing occur. In average eyes, we'll complete the rhexis with forceps. This is a 74-year-old female who has slightly more than 1 diopter of corneal astigmatism. We can see the 6 o'clock mark having faded a bit there, and a 3 and 9 o'clock orientation mark. And in this case, we'll use a Mendez type of gauge that actually has the numerals on it. Some surgeons prefer that rather than the less descript kind of blank 10-degree marks that I use on my particular fixation ring. So we'll align the 90-degree axis up, the 180, and we'll place a mark at 95 where we will center our incisions right about there. Quite honestly, proper centration far outweighs the arc length accuracy of the incision. Centration is really what it is all about. Fixation ring, please. We could place additional marks to delineate the start and finishing points of the incisions, but in this case, rather, we'll just work off of the fixation ring. We'll count over 10, 20 degrees. The total arc length based on the nomogram is 40 degrees, so we'll place the diamond in the peripheral most extent of clear corneal tissue, scribe a gentle arc with my left hand, pulling the blade toward myself. If we were to see epithelial drag, we would stop, come out, and re-enter such that we did not pull off a large leaflet of epithelium in there. In fact, we did get a little bit of drag. We'll finish the incision for a full 40 degrees. We'll reposition the instruments. The fixation ring is now in my left hand. We will center over the 95-degree axis. Blade is in the right hand. We'll count over 10, 20 degrees to the upper edge of the hash mark. Place the blade perpendicular to the corneal surface and pull it toward ourselves, visually extrapolating to the ring right to that point for a total arc length of 40 degrees. Again, marks could have been placed if that is preferred. Side port incision is now placed outside of the extent of the LRI. We try not to intersect those two incisions. Fixate the globe with the modified fixation ring, and this is the Mastel Super Stealth diamond keratome. The front shoulder is 2.3 millimeters in width, and the base is 2.8. The phaco needle and sleeve combination that we use, the microseal or microflow, requires about a 2.5 millimeter incision. So we'll stop right there for a 2.3 internal and about a 2.5 or 2.6 external incision. Particular patient, we have almost a diopter and a half of with the rule astigmatism at the 115 axis, and we always bring in to the OR a written sheet of sorts going over the patient's history and telling us exactly what to do. The most common error encountered when performing LRIs is to operate on the wrong axis, and if it's the wrong axis, it's likely to be the opposite axis, and we wind up doubling and making the patient's astigmatism worse. So in this case, we are going to center our incisions over the steep 115-degree axis, that's plus cylinder. We have a faint 6 o'clock mark right there. To find the 115-degree axis, we'll use this Mendez gauge. We can also work off of the fixation ring that I use that has no numerals. It just has 10-degree marks, but sometimes that can be a little confusing. So if you prefer to actually see the numerals, we'll use an instrument such as this, and we'll line up the 90-degree mark with the 6 o'clock ink mark that is placed. It's rather faint, but I can see it through the microscope. And then we'll use this 2-incision RK marker to mark the 115-degree axis in this particular case. And we'll center the central portion of the instrument over where we think the visual axis is, and then find 115 right.
You need the shorter too, right?
Sure do.
They just mark one side and then the other.
And we'll mark 115 and 115. And that's where we're going to center our incisions. May I have the other ring, please, Tammy, and then irrigate? And in this case, based on the patient's age and our nomogram, the arc length of the incisions should be between 40 and 50 degrees. We'll place the broad hash marks over the steep central meridian, and then we'll count over 10, 20 degrees, and we'll place a mark showing one extent of the incision, and then we'll count over opposite 10, 20 degrees. Again, each mark delineates 10 degrees of arc. We work in degrees of arc rather than millimeters so that we don't have a relative overcorrection in small eyes nor a undercorrection in larger eyes. Grasp the eye, and we can move the eye if necessary with the fixation ring to optimize exposure. Place the diamond perpendicular to the corneal surface at the peripheral most extent of clear corneal tissue, irrespective of pannus. In this case, we're using the classic empirically set diamond at 600 microns without pachymetry readings. We use that in quote-unquote routine phaco and cataract surgery, in refractive lens exchange or multifocal IOLs where we're really trying to optimize absolute accuracy. Pachymetry is taken and we adjust the diamond based on pachymetric readings. So this is an empirically set or classic approach, 600 microns. Diamond now is held in my right hand, and we scribe a gentle arc just inside the limbus. So these are really truly intralimbal, not limbal, relaxing incisions. Side port is then created with the fine trimen. I have absolutely, positively given up on steel blades. There is no question incisions are far more reliable, they're exquisite, in fact, and I really think that the side port oftentimes is neglected. It leaks, frankly, more often than does the main incision, especially with steel blades. So I would strongly encourage you to consider the investment, and over time actually saves money. This is the Rhine 3D diamond that we're going to use. It's a 2.5 millimeter width that we use with our micro coaxial sleeve and tip combination. And you can see in this case the depth of the tunnel is actually greater than the width of the incision, and that really assures wound stability. In most cases, we do like to utilize some form of intraoperative keratoscopy to confirm the steep meridian. This is the Maloney keratoscope made by Katina and other companies, a very popular and useful device. And in my left hand is a smaller, a more petite type of instrument designed by Tom Neuhan of Germany, and this is made by Mastel Precision, and gives a very crisp, easily recognized corneal mire. And with some practice, one can get to the point where they can recognize perhaps as small as a diopter to a diopter and a half of corneal astigmatism. It is also helpful to lift up the weight of the speculum off of the eye, which can influence the mire to some degree. And just another way of staying safe and being sure that the incisions are centered over the steep meridian. I trust that with those keratoscopes, one could appreciate that the steep meridian, in this particular case, is at the 110 axis, that being the shorter portion of the oval light reflex, this being the longer or flat axis. Now in this particular case, again, steep meridian is at 110. You have a marking pen, Tam, or 2-cut RK marker, either one. Okay. All right, there's our 6 o'clock mark, and we'll line that up with a 90-degree axis. We want to mark 110, our steep meridian. Well, I'm just going to switch hands here. And we'll place a mark here at 110. And in this particular case, we are calling for a pair of arcuate incisions of 50 degrees. We're going to demonstrate the use of the Jarvie-Mendez ring. We're going to line up the zeros over the steep meridian, which we've marked here at 110. And the nomogram is calling for 50-degree arcuate incisions. So in this fashion, we can count right over to 50 and 50 and make 2 marks. One. Not much ink on here, but the impression is quite visible. And a second mark here, delineating 50 degrees of arc. Hold real still here, Keith. We'll fixate the globe with my right hand. And again, a 50-degree arc, so you can see our mark here is 1025. And we'll scribe a gentle arc. Reposition our hand. We're going to want to end right at that mark for a complete 50-degree incision. Right there. Go up to the other side. Switch hands. 1025, and there is the mark, faint but visible. And we'll pull the blade toward ourselves, keeping the foot plate even against the limbus, twisting the blade as we advance it. A little bit further, we want to end right about there. We'll dive back into the incision and end right there. I like to hold the diamond as if one were throwing a dart. And that fashion, as we move the blade, we can rotate it and scribe that gentle arc. We'll keep the side port incision outside of the extent of the LRI, and then create the temporal clear corneal incision, which, as we've stated before, although it appears to be planar, single plane, is actually more of a triplanar incision where we enter the eye somewhat in a downward fashion, then plane up, and then break through decimes. So we'll begin by leading with the point of the blade and then moving upward toward the corneal dome, creating an adequately long tunnel, and then pierce through the decimes membrane in that third direction, creating a nice square incision which will be very, very secure at the end of the case. In this particular patient, we have a fairly small amount of against the rule astigmatism at 175, just a little bit under 1 diopter. However, we know from our keratorefractive experience that as little as 0.75 will cause ghosting and symptoms. We're going to keep it a little on the dry side, Tammy, so we can mark the cornea. We have our 6 o'clock mark already established. As you can see, this Mendez ring will allow us to identify the 175-degree axis, where we'll place a mark identifying the steep meridian over which the incisions will be centered. Again, centration is very, very important. Euler's theorem, which was described decades ago, tells us that a error of just 5 degrees being off axis can result in as much as a 17% reduction in effect, a 10-degree error, 33% reduction, and if we're off by 15 degrees, might as well not even be using incisions. We're going to probably make the situation worse. So centration really is the key. So now, to delineate the extent of the incisions, we're going to place this Jarvie-Mendez ring over the steep meridian, line up the zeros, and our nomogram is calling for incisions of 35 degrees. So we're going to count over to 35 on each side and place a mark. And now an additional mark on the opposite side. We are again using the preset, 600 micron classic LRI blade. Now, it's very important to be perpendicular to the limbus rather than perpendicular to the floor. So, John, we're going to ask you to look a little bit to your right. At the same time, we'll steady the globe with the fixation ring, and in this fashion, we can really be perpendicular and not create a gaping incision. And now we'll have you look a little bit to your left. Excellent. And if we get a little epithelial drag, we just come out and then re-enter. And if anything, we create a few small tags of loosened epithelium rather than removing a whole sheet. I prefer to go up against one edge or the other at mid-stromal depth, creating an adequately deep tunnel. This particular patient is relatively spherical, so we will not be performing LRIs, but we will talk a little bit about our general incisions. Again, the side port really is an important incision which is often neglected or overlooked really with regard to its design and in particular its sizing. We routinely use a dedicated diamond blade for the side port incision. We find that its ability to seal is far superior compared to that when using a steel blade. This is the fine trimond made by Mastel, and we limit its width to about 600 to 700 microns. This is the new diamond that actually has an inscription on it, which is a bit novel. To create an adequate depth or length of the incision, one really needs to begin a bit more perpendicular rather than beveled, and then aim up toward the corneal dome by simply pulling up on the blade and then piercing through Descemet's membrane. So it's perhaps more of a triplanar dissection, but the change in angulation is very, very subtle. So we'll begin by impregnating the tip of the diamond into the tissue and then flatten or applanate and head upward anteriorly toward the corneal dome, making sure that we're not listing to the right or left. That will possibly create a sort of a smiley curve type external incision, and we're watching the tip of the blade to be sure that we have an adequate depth created, and then we'll aim back downward toward the iris to pierce the Descemet's membrane, and in this case advance the blade up to the leading shoulder, which is approximately 2.3 millimeters internally and about 2.5 externally. In this particular case, we will be performing a refractive lens exchange on a 59-year-old patient who is nearly a +4 hyperope. She has a small amount of with-the-rule astigmatism, and we will be placing arcuate incisions over the steep 85-degree meridian, and each incision will delineate between 40 and 45 degrees of arc. With refractive lens exchange, as well as premium presbyopia correcting IOLs, we routinely use the Napa nomogram, which incorporates pachymetry measurements. The measurements can be taken either preoperatively or here on the table. We have essentially sterilized the tip of the pachymeter using alcohol, but we'll take care not to touch any of the drape or speculum. Carol, I'm going to ask you to look up above the light a little bit. Excellent. And we'll here take some readings over the intended incision site.
849, 809, 823, 817.
As is the case with a hyperope, we're getting very thick readings.
795, 826.
So maybe 790 would be our thinnest reading.
871.
Carol, I'd like you to look down now, just below the light. So a few readings over the intended incision site, the extent of the incision.
831, 831, 839, 833, 870.
Okay, about 830 for the superior incision. And using the Napa adjustable micrometer blade, we will take off approximately 10% of that reading. And this is the adjustable micrometer Napa diamond by Mastel Precision. All diamond blades really need to be inspected regularly on some type of measuring device, both to be sure that the diamond is in a good status, but also that the extension is accurate. Some surgeons still have older micron scopes around the OR or office that we had used during the RK days, but I think newer devices will hit the market very soon. So we can see that the micrometer handle here is set at 0 as we match the two zeros up, And we'll verify that by inspecting the diamond, and we can see that it is right at the edge of the footplate. And we'll extend the blade now out to the 50 mark, which is 500 microns, 600 microns, 700 microns, and we measured, what was it, Tammy? 780. So we'll cut it about 710 right there inferiorly. We have demonstrated several different ways to mark the cornea, delineate the extent of arc. Quite frankly, in most cases, my technique is very straightforward. We work off of the 6 o'clock mark, and then without an actual Mendez gauge, just with this fixation ring, knowing where 6 o'clock is, we can essentially determine any other position using this ring, since each mark represents 10 degrees of arc. So if we wanted to go over 45 degrees, this would be the axis right here, 10, 20, 30, 45. In this case, the steep meridian is at 85, so we'll just move over 5 degrees, just past the 6 o'clock mark here in this left eye. The nomogram is calling for an incision of 40 to 45 degrees. So we'll count over 10, 20, we'll begin here, and we'll end right about here. And it's actually fairly easy to make a little radial visual extrapolation to the appropriate point on the limbus. And then we'll pull the blade toward ourselves, scribing a gentle arc. Exposure, as you can see, is a key element to the technique, keeping the footplate perpendicular right to about there. 10, 20, 30, 40 degrees, maybe a hair over there. We measured 830 for the superior incision, so we'll take off 80. That would be about 750. Maybe note that when we extend the blade, it's important always to extend outward. If we go past our mark, you want to come back below it and then finish as you're extending out to eliminate backlash. There's 750. I think we'll back off just a little bit to about 745. Now, that's a great position there, Carol. We'll center our hash marks over the steep 85-degree meridian. Count over 10, 20, 10, 20, so that's going to be the extent of our incision. Peripheral most extent of clear corneal tissue. And we'll pull the blade toward ourselves as we scribe a gentle arc, rotating the diamond. 10, 20, 30, 40. We'll create our side port diamond on either side of the LRI, not through it. And we'll create our phaco incision, once again, almost in a triplanar fashion. And once we embed the nose of the diamond, we then head up toward the corneal dome and then through decimes. Appears to be a single plane incision, but again, just a little bit of a triplanar motion helps create a longer tunnel, which is a safer, more secure incision. This very pleasant 66-year-old patient has a modest amount of with the rule astigmatism at the 115-degree axis. And according to the standard cataract nomogram, we are calling for a pair of arcuate incisions of 40 degrees over the 115-degree meridian. As you can see, we have a 6 o'clock mark right there. So according here to the ring, we can determine, either using a Mendez gauge or the fixation ring, precisely where 115 degrees is by simply counting over. Each one of these marks delineates 10 degrees of arc. As such, 115 would be right over this point. $10 and $15, 10 and 5. So that's 115 right there. And as I mentioned, we are going to create 40-degree arcuate incisions. So we'll mark the starting and ending point of the incisions, which will be 10 and 20 degrees on each side of the broad hash mark. Alternatively, one can just use the ring and visually extrapolate without actual marks on the cornea. But it's nice sometimes to see precisely where one wants to start and finish the incisions. In this case, we're using the empirically set classic diamond at 600 microns without pachymetry. We place the incision at the peripheral most extent of clear corneal tissue, irrespective of vascular pannus. So you can see a moderate amount of vascularization here, so we expect to see a few erythrocytes visiting this area here. That is the superior cut, and we'll create the inferior incision. Very important to keep the blade perpendicular to the corneal surface. With that said, Lucille, I'm going to ask you to look up above the light a little bit, and we'll move the globe with the fixation ring so that we can come in perpendicular to the corneal surface. Peripheral most extent of clear corneal tissue. We'll pull the blade toward ourselves, creating a gentle arc circumparallel to the limbus. Side port incision will be placed outside of the arcuate incision. Normally I prefer my non-dominant right hand to be placed right there at the 6 o'clock position, but the side port manipulator would create significant gaping if that incision were placed through the LRI. We'll firm the globe up with lidocaine, and now we'll create the single plane temporal clear corneal incision. This is the Rhine 3D diamond, which I find to be superb in creating a consistent, sealable incision. We actually don't create truly a single plane incision, but rather almost a triplanar incision. We begin down a little bit and then dissect upward and then pierce through decimes back in a downward fashion. So down, up, and then down through decimes, creating a square-like incision which will yield an excellent seal.